Yeah, we are talking about pathological fractures. Pathological fractures are very, it's sort of interesting, right? Because if you are interested in diagnostics and all, so pathological fractures are like a little bit interesting. So, okay. First of all, pathological fracture definition is the fracture is due to the underlying cause, and the most common cause of the pathological fractures are osteoporosis. So, what is osteoporosis? Osteoporosis is nothing but it is a bone resorption. Bone resorption is due to mainly two reasons. Is due to hyperactivity of the osteoclasts, which are responsible for the bone resorption, or osteoblastic activity is reduced. Okay, just remember these two things. So for because of osteoporosis, and this is the most common reason for pathological fractures. Okay, shall we go for other causes? Other causes like what? Major causes like osteogenesis at birth, osteogenesis imperfecta, osteomalacia, and other diseases, and cancerous conditions like benign and malignant. So for benign we have granulosa cell tumors, and uh, benign tumors are GCTs, and okay, and malignant tumors are mainly sarcomas. So sarcomas and other groups like enchondromas. So these are the cancerous conditions which are responsible for the pathological fractures, and so many conditions are also responsible like aneurysmal bone cyst, simple bone cyst, and and enchondromas. So these are also responsible for the pathological fracture of the bone. Okay, and other conditions also like engendrance rickets, and vitamin D deficiency rickets, or in that types also vitamin D resistant rickets, or other conditions are also responsible in rickets. We will discuss while we are discussing about the rickets, and Skadway, and etc. All these are vitamin deficiency conditions where these are also lead to pathological like pathological fractures of the bone. So cystic lesions mainly cystic lesions are mainly related to the bone, like see pyogenic osteomyelitis. It is a major infections which are also lead to the pathological fractures, pyogenic and tubercular osteomyelitis. And when we see an cystic lesions on the bone, we have to suspect whether it is an osteomyelitis or it is a malignancy. Okay, guys, we are doing good. Now we are. These are about pathological fractures and all. So, okay, these are the types of fractures. Various conditions. Just I explained to you. Now we will go for other conditions in just injuries around the bone. First of all, we have to start with the skin. Skin is underlying subcutaneous tissue, muscles, tendons, and ligaments, tendon ligaments, and periostea, bone. So what about injuries about these structures which had impact on a patient's conditions, like see in RTS or any injuries, or any involuntary or involuntary injuries, or slip and falls, everything they again there is an mode of injuries and other I will explain you in the types of fractures when we are discussing about regional fractures or particular part. Then we will discuss about the pattern of the injury. I mean, mode of injuries and all. So first of all, we have to see is there any hematoma, bruise, or like. So hematoma, bruise are comes under the skin and all. So when we have to look about hematomas and bruise, because while we are managing a fracture, first of all we need to stabilize the patient, so we have to apply an POP, that is a plaster of Paris or a slab-oric caster. So if there is an hematorosis or I mean that bruise and all, so we have to take care, we have to leave it for a while, otherwise it leads to a skin burns or all or any swellings. It leads to exaggeration of the swellings and all. It might leads to formation of blisters, or it may leads to any infections and all, okay, or it may leads to a compartment pressure, increase in compartment pressure, which ultimately leads to a compartment syndrome. So if there is an bruise or hematoma, chemosis, everything, just wait for to reduce and okay, first, okay, this is the one thing, skincare. So everything we have to manage with the mother. First of all, things are only this is the skin, and coming to the coming to the ligaments, injury to the ligaments, we call it as a sprain. So when there is an injury to the ligament, we call it as a sprain. There are there are 4 degree sprains: first degree, second degree, third degree, fourth. So first degree is normal tear. There is no much tear. First and second degrees there is no much tear and all. Third and fourth degree have a marked tear. So according to that we have to manage the patient. So first degree tear and second degree tear we have to manage with the conservative management, just with an ice compression therapies or the normal analgesics and NSAIDs, or we can manage with these 3 things. So when there is a marked injury to the ligaments, that is a 3rd degree sprain or 4th degree sprain, we will go for immobilization for 1 to 2 weeks, that is plating or casting. And remember that don't immobilize the patient more than 2 weeks. So you have to mobilize the patient early. And this is for the ligamentous injury. So muscle injury is called a strain. So injury to the muscle is called strain. So muscular injuries, it might be due to the high velocity injuries. Is there any? We have to look at for any tendon injuries. So if there is some tendon injuries, we have to see if there is any gap. The most commonly we have to come across is the Achilles tendon injury or the heel. We know. So Achilles tendon injury. Achilles tendon injury, how we okay, I will tell you step by step. First of all, is there any gap you suspect? You have to suture it, or end-to-end suturing there. You have to. If there is more gap is there, means you have to fill it with the tendon graft. So muscular injuries, this is for tendon injury. Muscular injuries are also, is there any muscle belly tear or what, you have to see. Otherwise you have to repair it over there. So at the time of injuries, at the time of fracture management, you have to look at carefully as possible as you just have to evaluate uh, each and every part of the injured site, including nerves and vessels. Is there any neurovascular compromise or there? You have to check it. How you check means vascular means you have to check for peripheral pulsations or Kurgami skins. Okay, for that basic. Next, for neurological, you have to first of all you have to explore the wound. Is there any tear or not, and just check for the peripheral sensations and any. If there is any possibility or patient is operable, is there any obstruction to the patient, then you can check for reflexes, but at that time it might not be possible, or it might not be seems good, that is inconvenient to the patient. This is the introduction as what we discussed, that is what is a bone and how it is made up of, what is made up of, components and types of fractures, and all types of fractures with examples, and about ligaments and muscle injuries, tendon injuries, how we manage. So generally whatever the fracture, whatever, wherever, first we have to stabilize the patients, we have to check the vitals, we have to provide adequate fluids, you have to check monitor vitals, is there any hypotension or tachycardia. We have to stabilize the patient first in all these aspects. Okay, then stabilize the patient or fracture site with the POPs like slab. Uh, if it is an open wound or there is a much swelling, always go for slabs. If there is no swelling or an open wound, just go for a cast. It is a closed, just go for a cast. And almost we can stabilize a patient, we can use like PV frames, Thomas plates, all these are available to stabilize the patient's skin tractions. All this I will discuss later it on very uh, we can discuss it on later. So as far as I hope you people can enjoy this session of teaching. Thank you.